you're caring for patients. We're going to focus a lot of this also on end-of-life care and some of the issues that are involved in that, because that, I think, is what gives people the most angina, and particularly in relation to this question of withholding and withdrawing. So to start out, I just want to give you this quote. I love this. It's the opening of Dickens' Tale of Two Cities. It was the best of times. It was the worst of times. It was an age of wisdom. It was an age of foolishness. It was an epic of belief. It was an epic of incredulity. It was a season of light. It was the season of darkness. It was the spring of hope. It was the winter of despair. Dickens talks about two cities in his epic work. And these cities on the surface are London and Paris. And he clearly is contrasting the two of them. London and Paris during the time of the French Revolution and before were vastly different places, but he also points out they're not all that different. There was rampant injustice, there was rampant inequality, there are riot scenes in both cities, there are unjust trials in both cities. And as you probably know, Dickens was very interested in this issue of promoting justice and equity in his world. There's also this sense in which the protagonists in this, and I'm not going to give you the whole synopsis, it would take too long, but they're caught in this liminal state between the two cities, and caught particularly between love and loss. And I would argue that some of our patients are in similar positions when they're facing end-of-life care. There are extremely complex relational dynamics that are explored throughout this book, particularly in relation to families. That happens to our patients as well. There is hope and death that is predominant throughout all of it. And of course, a lot of it revolves around, those of you who know the book know it revolves around the idea of redemption. There are two other cities that we want to talk about, ethics and cardiology. And they're very much contrasted most of the time. You think about ethics, kind of low tech, just takes one of us showing up, right? No cath, no ECMO, no anything else. Obviously talking about humanistic and human-centered things. I can tell you, as someone who's tried to do empirical ethics, it is very difficult to study and generate research work on. We like to talk about quality of life. We do extremely inexpensive things. We don't get paid a whole lot for our ethics consultation. And we talk about things like good death. Very different from what we're discussing most of the time in cardiology. We're obviously extremely high tech, especially a place like this. We're mechanistic and mechanical. We are data-driven, baby. We are very interventional. We talk about life prolongation most of the time, but of course, increasingly about quality of life. We cost everybody a lot of money. And maybe our idea is, well, let's just give them a chance. And of course, as we all know, give them a chance at what? But really, we're here because we want to merge these two cities to see that they really aren't all that different. And we have many ways in which there's synergy between the two. So here's the plan. We're going to present three cases, clinical case presentation by yours truly, and then you get a chance to weigh in. We're going to have some audience poll questions. There's going to be a QR code on the screen that you can use your phones to jump into. And Dawn is going to give us the verbal report of the percentages for this because we couldn't figure out how to do it on the screen. Then Denise will give us the ethical analysis presentation. I will give you the denouement. And then we will hopefully have a little bit of discussion, and hopefully we'll get through the three cases. If not, that's okay. One word of caution, all of these cases are based on a true story. These all are based on ethics consultations to our service here from cardiology. But that also means we have to be careful about PHI. Some people may remember these cases. I have changed the PHI, obviously, but I really want to just help everyone understand, if you are tempted in your comment or question to reveal PHI that should not be revealed, please do not do that. Madame Defarge is knitting and watching. So here's our first case. 68-year-old, non-ischemic cardiomyopathy, comes to the emergency department, dyspnea and chest pain. Admitted to our CCU service with acute decompensated heart failure. The EF was 10 to 15. Has an ICD already, normal QRS, and no biventricular pacemaker. Diabetes, hypertension, CKD stage 3. Obstructive sleep apnea with a generous BMI. already on a DOAC for a DVT, and has had multiple readmissions for similar presentations in the last 8 months. No illicits, lives with her daughter. Her daughter's in trade school. This was a big deal for the family. The patient was a former factory worker without significant toxic exposures. There's really nothing in the family history that would be helpful. At this point, the patient is inotropic dependent and spends the next 2 months between the CCU, the CARDS A, CARDS C service back and forth. Hypotension, symptomatic lightheadedness would land the patient back in the CCU for congestion, diuresis, and inotropic titration. Along the way, of course, the patient ends up with several UTIs, 1 episode of hospital-acquired pneumonia. Creatinine is above the baseline and hasn't gone down. The patient cannot tolerate CPAP overnight, actually never really tolerated it at home. No ICD shocks, but there's a lot of ectopy that makes everybody a little bit worried. And thing I didn't tell you earlier, the prior admission had been for less than 2 weeks. Now we are going on and on over months. Goals of care discussions, unfortunately, have been quite challenging. Been vacillating in regards to code status. At times, the patient would agree to a DNAR, but always refused ICD deactivation, then someone would go backwards to being full code. The daughter has been named as the surrogate, but interestingly, on the form, on the living will part of the advanced directive form, the section that talks about limitations to interventions was purposely crossed out and initialed. The patient stated she does not wish to undergo invasive interventions that have little hope of success. Wants to go home. She's got a bunch of cats there. Like to spend time with the cats. She's very concerned about finances, particularly being able to fund her daughter's education. And so this has actually come up a lot in discussions in regards to hospice and actually also long-term care facilities. Is not interested in hospice, particularly if it's going to be a financial drain on the family or involve some loss of autonomy. So let's actually give you now the chance to scan the QR code, answer some of these questions. And while you're scanning that, and you're watching from wherever you are remotely, please feel free to do that. And I want to particularly introduce James Fausto, who is the director of the Palliative Care Service for the University of Washington. He is our remote expert, who hopefully will be able to provide some remote commentary on some of these cases, and particularly what's going on. So we're very, very glad to have Jim join us today. Thank you, Jim. All right, so everyone's ready?
Appreciate it.
Audience question 1. Is it really a do not resuscitate order if a patient doesn't want to turn off an ICD? What do you think? Hopefully everybody's been able to get in. All right. I'm gauging this by heads turned down, looking at phones. So it looks like there's a number of heads going up. Let's go on to question 2. Is it ethical, moral for a clinician to turn off a patient's ICD against patient or family / appropriate surrogate's wishes? And we gave you a maybe here, threw you a bone. So I'm going to keep that up and ask for any comments while Don is tabulating our results. Any comments? Yes, Chinoso. You need to have the mic there so people can hear you.
Great, awesome. I think one comment I think that's important to keep in mind is that just because an ICD fires doesn't mean it's going to be effective. But I think we have to keep in mind that, you know, the physical and emotional pain to the patient. You know, but there are many things to consider. But
yes,
that's just one thing among them.
It is not as simple as many of us make it out to be. That's a very good point. Don, are we ready with the results?
Okay, so we had 31 people respond, and for the first question, it's 32 now, 37.5% said no, and 62.5% said yes.
Interesting. Good split. And how about question 2?
So for question 2, 37.5% said maybe, 3.1% said yes, and 59.4% said no.
Very interesting. We'll show you a little bit of empirical data later in Denise's part on particularly that last question in regards to electrophysiology practitioners. So let me turn it over now to the esteemed Dr. Dudzinski.
Okay, thanks, Jim. And so can you hear me okay? Or am I too loud? Okay, terrific. So I just want to go over some higher level ethical issues that arise. And then those of you you can see I'm not a clinician myself, so I don't know all the ins and outs sometimes, so I'll let you help me drill down, and we've got Jim here as well. So some of the ethical issues include the importance of goals of care conversations, and some of that plays into our withholding and withdrawal policy and what we can do in that policy that provides very specific guidance for clinicians in situations like this. And really, what does it mean? And hopefully Jim can also weigh in a little bit. What does it mean to have a code with an ICD in place? What has it meant for your patients? And then the notion of assent and when and where that might be appropriate in some of these cases. So how many people here are familiar with the withholding and withdrawal policy that we have? Okay, good. I'm glad that we're doing this. Okay. So when you get into this sort of situation where there's complexity in decision-making about end-of-life care and a shift, particularly when most of you as clinicians are beginning to agree that we should be thinking seriously about a shift to comfort care, for example. We have a policy, Jim and I just revised it, that is designed specifically to walk you through what to do. And the goal of this policy is basically so that you don't get to the point where you end up trying to have to make a unilateral withdrawal decision. You're doing everything else in your power with the help of many other services like palliative care and ethics, et cetera. The way you get to this, I know you guys get into these places in different ways, is you go to the clinical toolkit, you go to the policy center, you search a policy, and one will come up that says withholding and withdrawing of life-sustaining treatments in adults. And I'm telling you, you just follow this policy step by step, and it will help you immensely, and you don't have to reinvent the wheel, okay? So some of the key elements of our withholding and withdrawal policy is, number one, any unilateral withdrawal where we don't have at least assent from the patient or their surrogates should be exceedingly rare, right? This should almost never happen, but it is ethically permissible sometimes. But we try not to have to avail ourselves of that. Always, as you'll see in the policy, palliative care is always involved in these difficult ones. Ethics often is. And the medical director, if we're getting to the point where we're talking about unilateral withdrawal, the medical director needs to be involved, because this is also an institutional decision, right? There are institutional impacts of that. So a couple of the key features are that of this policy is that, especially if you have somebody who you think is very, very ill, you want to establish in a clear way goals of care soon after their admission. Work with them on establishing those and be clear about what you can offer clinically. And think about enlisting palliative care when the patient has life-limiting or terminal illness, or when your patient has gotten to that place. The attending then will seek consensus among the treating teams, and this includes nursing. So the idea here is that usually all of you who care for patients like this, you'll come to the place of it being time to think about withdrawal at different times, but when you're all pretty much there, that's a signal to us in ethics. It's a signal in palliative care. It says, some of the more issues that are morally discerning, people discern in different ways, we're getting to that place. So we don't want to be talking to patients and families about shifting to comfort care, particularly if they strongly disagree, if you don't agree, right? That doesn't make any sense. We want to keep all of that away from the family until we can come to agreement. We're here to help with that. Palliative care is here to help with that if you need help with it, but keep it away from the family. If there's persistent disagreement, you can always call us, ethics. And if the clinicians do agree with the withholding and withdrawal plan, and you want to strongly recommend turning off that ICD, for example, and shifting to comfort care, what you are often going to be seeking is not traditional consent, but it's assent. Are people familiar with this notion? So this has basically happened. Sometimes clinically, the picture's clearer. You can see that the patient's body has its limitations and it's coming to the point where it's hitting those limitations. This isn't the same as saying, here are two equally good treatments, choose one. This is when you're really telling in a very compassionate way, this is where we are. This is what I want to do. This is what we think is most appropriate to do. Yes or no, loved one. Yes or no, patient, right? And there are two advantages of this. You take some of the onus of responsibility for that difficult decision away from family members. You take on a little bit more. And there's still an opportunity for the family to dissent. If they dissent, if they say no way, then we stop, we're not going to keep going. Then we move through the policy even more. But it gives you an opportunity to change things. If you pose a question where there's only one good answer and you pose it as a question as though there are two or three, you'll get the second and third answer you don't want, right? Meaning, and that's why this is only appropriate when people are extremely ill, right? This isn't true all of the time. If the patient assents, then let's say it's something like a DNR, you could proceed. And depending on the circumstances, often withdraw life-sustaining treatment with that assent, because you are telling them what's going to happen. You're telling them why. You're just holding more of the responsibility for that, because to you as clinicians, there's only one good answer. There's only one good option anymore. Often as part of this, if there's dissent from the family, there may be a time trial where we say, hey, let's look at what's happening to this patient in this short period of time, come back together and talk about it in a few days and see if we're seeing similar things, right? And palliative care can help with that. And then if disagreement persists, we want to enlist the service chief and then the medical director. The last thing I want to say that's part of this policy is that if, for example, the previous attending went through a lot of the work to get to the place where we're getting to the family agreeing to withdrawing, and everybody thinks it's appropriate, unless there's a truly clinical change, we want to keep that consistent as we change attendings, right? So that we're not starting over this whole process again with every new attending, okay? So now I'm going to pause, and Jim, I see that you're on. If you have a moment, Jim is also taking care of his young children. So if he's available, is there anything you want to say?
Are you able to hear me? Are you able to hear me or no? Nope.
Okay, we're going to listen carefully.
You can hear me, okay? The only thing I would add, Denise, is I think that last point you made, really important as you hand off to a colleague to say, like, I used a model of assent. So it's not only like, don't revisit it, but I would also just emphasize that, like, we actually used assent in this process, as opposed to, because sometimes things change and people may ask, well, is that really what you wanted to do? And I would just, make sure there's understanding that we gave a recommendation and they assented to this. Because I think these can be easily undone, and a person who assents to stop something, they may easily assent to restart something. And so just make sure that handoff is really tight. But otherwise, everything you've said is wonderful.
Sure. So we actually, a few years ago, we were very interested in this question of unilateral deactivation of ICDs. There was a thought piece that went in and said, you know what, if you try to do this, it's battery. It's a legal case of battery because you're touching the patient, doing something against the patient's will. Now that becomes interesting with remote deactivation, of course, because then you're not touching the patient. But we surveyed patients from the practitioners of the Heart Rhythm Society to see what they thought, and it was very interesting to look at that versus patients and what the patients actually thought. Most of them in both categories actually thought the device should not be unilaterally deactivated, but you can see that quite similar amounts actually thought that it should be. And this was a situation in which two physicians agreed that there was a situation of futility.
Thanks, Jim. Okay. I just want to go a little, I can see maybe not everybody is completely comfortable with assent, and we can maybe have a whole conversation about that at another time. It is only used in a minority of cases, but I want to just say, this is to agree with something or concur. It is not choosing something. They're concurring with your recommendation. And it's more than a recommendation. It's like an urgent, this is the only thing that we think is appropriate, right? And so in these situations, when you're talking to families under these circumstances, you are telling compassionately, you're not asking. They can still say, no, doctor, and then we do something different. But you're telling, and every interaction, you need to go in knowing that you're having a telling conversation, not an asking conversation. Back to Jim's point, where you need to tell your colleagues it's an assent kind of discussion. We use this a lot with children, of course, and adults with diminished capacity. This is sometimes also called informed non-dissent. And is most appropriate in my mind when we're talking with competent adults who are helping to make decisions or making their own, when there's only one clinically appropriate course of action, right? Pretty much. And then you're all speaking with one voice. This is important. Obviously, this is going to be harder for the family if everybody who comes in is saying something different. So we want to all get on the same page. Palliative care helps with that. I think I went into all of the rest of this stuff. Okay. And then you can see here, of course, though, with my old eyes, I can't see, but you can see some information from the Journal of Hospital Medicine here about agreements and disagreements about how ICDs kind of play into no code. So on the right-hand side, I'm comfortable discussing ICD deactivation with patients. And you can see the most comfortable folks are geriatricians, and that cardiology is a close second. But you can see how there's also, with your colleagues, you're going to have different comfort level with these kinds of conversations. And of course, some of the coaching that we get from our colleagues who do this a lot and from palliative care can help us have more gentle discussions about this. In addition, I just want to point out here that there are some ways of talking about these things that have been published that can literally give you a little bit of a script to help you in these situations. And so I leave it here for you to take a quick look at. And again, Jim, if there are any tips you would provide us on how to have these conversations, we'd love to hear them.
I think the only one thing I'll say that's probably shifted since 2010 is the word understand can feel a little bit like you're testing people. And so sometimes we ask, like, how are you seeing your situation? Or what are some of the important things that you've taken away from talking with the doctors? Or what are some of the important things to you that the doctors have said? And that is a way to get to some of the questions without being like, what do you understand? Which for coming from a clinician can sometimes feel like, oh, they're checking me. So I don't know if that's helpful.
And number 4. All right, to go on with.
Great, thank you for these refinements. Yes.
One of my younger patients. Where she was very clear to say that it felt like she was really admitting the end by turning off the device. And so that whole concept of what does the device mean to you is where I've gone when I've navigated that, because it's been really interesting what that means to different patients and their families, which in some cases is that last bit of letting go. And then the decision about, do you turn it off, do you not, kind of, she took a couple of days. And then the other piece of it of, have they ever been shocked by it? Because if they've never been shocked by it, then the concept that it could hurt and everything else is outside there. But if they've only been shocked when they're completely out cold because they had VT or VF, then they've had a different experience. So I think that at navigating that idea of what has been your experience with this device? And, for the ones who can say it feels like a gorilla slammed me into a post, they're going to be pretty cool with turning it off, but for somebody who's never had the experience and it means that they're really giving up, then that time piece, I think, can be really helpful. But that was just insight from a patient.
Thank you. Very helpful. Any other comments? Yeah.
I'm concerned about the devices that have both arrhythmia treatment algorithms, but are also pacemakers.
This is a fascinating topic. There was actually a study that looked at time to death based on whether or not you turned off the pacing function along with the defibrillator function. There was no difference. So the general thinking for most people, and I'm not an electrophysiologist, so I probably shouldn't be talking too much about this, is that if you turn off the pacing function, they may just feel worse because now they're pacing at 40, or they're not, the heart rate's 40, they're lightheaded, and their last days are not so good. So unless there's very clear evidence that the pacemaker is prolonging life, at the end, it's probably best to leave it on. And then the deactivation would just be of the ICD and shocking function and probably ATP.
Okay. So there is a consensus statement again. It's a little bit old, but there's a consensus statement about some of this. So I bring it up here, and I know I'm taking too long, so I want to keep moving. But it is, I want you to be clear. I want to be clear that it is ethically and legally completely permissible to turn off a defibrillator in an ICD when somebody is dying. It's completely permissible. In fact, it's permissible to turn it off when someone says, I don't want it anymore, whether they're dying or not, as a matter of respect for that individual patient's autonomy. So I don't want you to worry that you're in some legal morass as that gets going. Okay, turn it over.
So the denouement of the case, this situation is very fortunate to happen here where we have amazing palliative care resources. In particular, the patient became progressively obtunded during one of the CCU admissions, the last one. And during a family meeting, the surrogate sort of was able to speak a bit more with her own voice and really agreed that comfort care would be in the best interest of the patient and to deactivation of the defibrillator. The patient ended up dying peacefully in a morphine drip, but this was 3 months after the patient was first admitted. So this is a very, very challenging case. Any other comments?
Do we know if she died an arrhythmic death?
That is a good question. My understanding is in the actual case is no.
Okay. I feel like I think this discussion is incredibly important, but I also feel like we fixate on the device being turned on or off a lot of times when someone's inotrope dependent and is likely going to die a death that's non-arrhythmic. And so while I think it's an important conversation to have, if I feel like it's going to compromise my trust and rapport with the patient, I feel like it's almost something I just put under the rug. Sometimes I don't know how other people feel, but that's just something that's crossed my mind a lot of the time when I'm in this situation.
It's a great point. And we love to categorize things in cardiology, as in most of medicine. This idea is arrhythmic, is it non-arrhythmic? And from the patient's perspective, sometimes it's incredibly important. And sometimes the meaning of the device, as Karen said, is super crucial to the patient's identity, their sense of security. They've been living with it forever. I had patients in some of my studies say, well, it never hurt me. Why would I turn it off? You know, as if you were anthropomorphizing the device. So I think that's a great point. We have to navigate that carefully. Well, in the interest of time, let's move on to case 2. This happened pre-COVID. So that's just an important thing to remember. 22-year-old college student, no past medical history whatsoever, presented to the outside hospital with respiratory infection, rapid decompensation leading to intubation and cardiogenic shock. And you can see the details here. Importantly, the right ventricle was shot, and there was no other valvular lesions and no pericardial effusion to drain. Transferred to us for VA ECMO. Persistent renal failure on hemodialysis, progressive ARDS, evolving necrotizing pneumonia, and this was all flu A positive. Yes, flu is still around. It was then, and it still is, and probably is going to make a comeback. 2 weeks later, into the hospitalization here, there'd been no significant improvement, unable to wean the ventilator, unable to wean the ECMO, dialysis dependent, and when sedation was attempted to be lifted, the patient was attended. Brain imaging was normal. There was no indication of that there was any sort of brain death. Of course, palliative care had been consulted. And then, of course, the patient developed right lower extremity gangrene from peripheral embolism. Vascular didn't believe that anything could or should be done about that. At this point, the surrogate agrees to DNAR status, and the decision was made for what was termed palliative extubation to a non-rebreather mask. However, at that point, the mental status improved. The patient became alert and was showing signs of interacting with the family. But there was not an ability to wean the ECMO by any criteria. There was minimal improvement in creatinine, and basically the patient was still dialysis dependent. And interestingly, the patient was extremely fatigued and could not engage in a longer, meaningful conversation about goals of care. And this was very much complicated. I wasn't entirely sure what even the nodding responses were. Of course, the patient 22, who does an advanced directive at 22 if you have no medical problems? You all should. Father was the primary surrogate decision maker. There was an older sister and a younger brother and a mother. All of them were deferring to the father. The patient also indicated, at least by nodding, that the father should serve as the surrogate. And up until all this point of palliative extubation, they had been pursuing all interventions. Of course, a 22-year-old college student with a sudden illness. And of course, after the palliative extubation and the mental status improvement, went right back to that. Let's do it all. And of course, at this point, palliative care started becoming the representative of the establishment, and we certainly wouldn't want to go down that route. And I am quite sure, I mean, we certainly get the Sun Ethics to know we're not going to talk to you because we know what you're going to tell us. And there began to be arguments with the nursing staff. And of course, multiple staff members at this point were also reporting that they believed that there was significant suffering on the part of the patient. So let's see what you think. Here is the QR code for case 2. Number 1, is it really do not attempt resuscitation if the patient surrogate doesn't want to remove VA ECMO? Don, go ahead and give us the results when you think that they've come in adequately.
We're at 19 right now. Should we wait for a few more? Oh, it's 24.
24 is good.
Okay. So for the first question, 62% said no. Well, 60% said no, and 40% said yes.
All right. I like this. It's not directly split there. And the second question, is it ethical or moral for a clinician to remove VA ECMO against wishes? So I don't know if people filled that out yet, but
Yes.
okay.
So 45% said maybe, 19% said no, and 35% said yes.
All right.
One quick question. So did the patient reverse the code status?
Yes, sorry, I should have made that very clear that code status was reversed. Yes. Excellent point. Now, of course, you guys are all highly accomplished academicians, so there has to be extra credit. Is there an ethical or moral difference between unilateral deactivation of an ICD and unilateral removal of a VA ECMO?
So 74% said yes, 9% said no, and 16% said maybe.
Fascinating. I think that's the biggest split that with most people who have voted for something out of all of our questions so far, nearly 75% say yes, there is a difference. This will make some very interesting discussions, but let's actually turn to Denise first for commentary.
No, I'm messing with the structure, but why? I have to ask. Is that okay? There was this difference, right? Would one or two of you mind telling me why you think there's a difference between? Yes.
I think in my mind, the deactivation of an ICD versus ECMO, also, we have to take into account sort of the ethical and moral obligations we have to not only the patient, but the utilization of resources that we have to our communities and, making those sorts of teams available to other patients. And I think that's the biggest difference in my mind, because an ICD, once it's implanted, isn't, as resource utilizing.
Yes, great. I think this gentleman and
If we have time. So I think one other thing is that the potential benefit of an ICD, if it's going to be effective, is going to be in the more medium to long term. Whereas for ECMO, it's going to be in the very short term. So I think that's important.
My sense is that the ICD is almost like the resuscitation piece, attempting resuscitation. It is not sustaining life. It's going to correct an arrhythmia if it occurs. You remove ECMO and you are hastening that person's demise actively by what you're choosing to do. And I think that's a moral and ethical difference that becomes relevant because we turn off and remove ECMO. There's also the physical capacity, like, yes, there's remote deactivation, but removing and turning off ECMO is a procedure that the patient will experience, which is also different than deactivating an ICD.
okay. And I'm going to speak to a couple of those things really quick. Also, I'm noticing this is saying our battery is low. Does anybody have a? Thank you very much. Okay, so the big worry, of course, is what I meant to be saying here with this poor bridge that's not going anywhere. This is what we're worried about with ECMO, right? That we put them on that bridge and we want them to get to the other side, whatever that other side is. And sometimes our patients don't, right? And it's the worry about the implications of this, both for the well-being of the patient, of course, and also for everybody who's involved when we're on this sort of bridge to nowhere. This is also a time where the withholding and withdrawal policy is going to help you very much. Again, go back to it because it will help you step through it. This is also going to be a situation for a couple of reasons. First of which, we have a very young patient who got the flu and is now on ECMO. And it is going to be emotionally so difficult for everybody involved. And then we add to that he's not recovering. And now we have to contemplate turning off ECMO, even when there have been moments when he's been alert and has been ostensibly saying to us, hey, my life is valuable when I'm alert. That may be some of the things that he's saying. And his family certainly is saying that. This is by far the most difficult withdrawal situation. You should go into it knowing it's going to be the most difficult kind of withdrawal situation, so we can support each other and get marshal the resources necessary to take care of the clinicians as well as the patient and family. Jim, if you were able to hear all of that, anything you want to add?
You said everything I would say.
Yay. Okay, great, thanks. Let's see. A couple of other things. I already talked about this issue of a very young patient. This is a time when, even if you're great at this, getting palliative care's help is gonna really help a lot, because they're one of the resources we have to support all of us in that endeavor, and they have a lot more experience with this. Here also, I want to be clear that from the get-go, before ECMO is begun, and I know it happens under emergent circumstances most of the time, but even before it's begun, we need to be sure that families understand that there is a time where we may need to stop it. And this to me is also a compassionate tell conversation, right? For all the reasons that were brought up before, there is a time where ECMO may no longer be able to deliver. Every one of these interventions is a means to an end. ECMO is a very intense means to an end, and it's temporary, right? People can't live on it for years and years and years like the ICD. Therefore, we need to make them aware upfront, and I'm gonna ask Jim a question about how to do that, and all of you in a moment. So, let's see, when I look at the patient education material about ECLS, this is one of the things that's listed. This is only appropriate when there is still a chance that the patient can recover. Now, of course, the most important consent conversations aren't written down, but the question I have is there a way, or how does it occur, that we put things in writing so people have something to hang on to when they lose track of all of the very many things that you've told them, about the fact that there is an endpoint with ECMO in a different way than there is with some of the other interventions that we use. So I want to pause here and ask maybe first Jim, because he's online, and then others, how you do that.
So I'm going to be thoughtful, I hope, in that I'm almost never involved in the conversations when I start it, but I do have a good sense that our cardiothoracic surgeons and our cardiothoracic team in general does a good job of telling people, like, this is something we will start and something we will stop. And I think most families I've talked to where we have to get to the place of stopping ECLS, if it's become uncertain from the family's perspective, will often acknowledge it was said or told to them at some point. So to that end, I don't want to overstate actually that I have that conversation at the beginning. I'm often the receiver of having someone done a good job doing that conversation. I'll pause there.
Thank you. But ethically, there is no difference between withholding an intervention that would be life-saving and withdrawing it. And this even includes something like ECMO, even when we are the ones intervening, because in many ways there are when you withdraw a ventilator, you're intervening there too, right? But there's so much dependency with ECMO, and as you pointed out and others, different people have different feelings about this, and that is real, and it will feel worse, right? But ethically, it is still permissible. And one of the ways I often ask people to think about it is, what if every time you ever had a medical intervention, you went into it and they said, you can never stop this, ever, right? If that were the case, we'd be in big trouble, right? Because that respect for autonomy allows us to say, this intervention that I had done under these circumstances is no longer helping me meet my goals, and I therefore want to stop it, no matter what it is, if it's a medical intervention, right? And so that's why both respect for autonomy, but then also the limitations of what an intervention can do in terms of helping people meet their goals is the other limiting factor that allows us and permits us to sometimes stop an intervention that we had started in good faith, thinking it could meet that goal. Okay. And this is also a situation where you might, the people involved might need help and support. And then as others have talked about, fair allocation of healthcare resources is a huge thing in ECMO, right? And the resources that are most important are you and your colleagues who have specialized training to help these kinds of folks, because they also have specialized training to help other kinds of folks, and we need them to help those folks. Okay. All right.
All right. So what happened in this particular case? The mental status actually began to worsen. Systemic infections took over. Family meeting, though contentious, resulted in a reinstatement of DNAR, initiation of comfort measures, and removal of ECMO, and the patient died peacefully. Doesn't always work out this way, as you know. Let me move on quickly to case 3. Oh, we have some questions first. I've said there was silence earlier, so I thought we would not have his comments.
Sorry, the question I just wanted to ask, I thought in particular, the family's sort of change in tone after the patient's mental status improved after extubation is really interesting to me, because I don't think I've certainly seen that, but I also think it's something that, you know, how patients respond to something going not as expected or perhaps not as they were told. And I'm interested just to hear more about, you know, what the conversations were, if there was any thought as to why the patient's family became actually antagonistic towards, you know, the palliative care team or whatever, versus seeing that as, you know, this is sort of an unexpected blessing to have more time with our family member, but they instead saw it as like, we have been betrayed, you know, by this team. We don't want to talk anymore. So was there any insight into sort of why that might have happened, or how conversations could have been handled differently to prevent that?
So this is a bit of a altered case to some extent as well. So let me actually open that up, maybe particularly to Jim Fausto and his comments. I know you've seen this before, and how those things can shift.
Yeah, so I will offer 3 points, I think. One is sometimes as a palliative care team, we're trying to respond to the clinical team's needs. And sometimes when they call us, they want to just revisit goals of care again and again and again. And so we will sometimes abide by that. We will also sometimes push back and say, I think we've done goals of care enough, and we just need to start making decisions as best we can. But so I think we are people and can be subject to folly. And so perhaps we went goals of care too many times. I don't know the specifics of this case, to be honest. 2, I think even in a case where a family says either I never want to talk to them, or we visit it and I don't want to talk to them again, as a team, if we can help you, especially in these really hard situations, sort of coach through conversations, that is a role we can play. So even though we don't get in front of the patient or family necessarily all the time, please know that we can still, like if the team says, the family says we don't want them involved, we can still be supportive to you, especially in these hard cases. And then I think 3, just in general, people put a lot of faith in clinicians, and when the course goes in a direction that we predict, they trust us. When there's an about face, it causes a lot of sort of loss or evasion of trust at times from the family's perspective. And I just wonder if that's a part of it, and we were sort of thrown in the mix of all this stuff and just sort of a trust evasion overall. Erosion, I should say, not evasion, but stop there.
Yeah, those are really, really good points. And I especially want to highlight this idea that palliative care doesn't necessarily have to see the patient to be helpful. I think that would be the same for ethics as well. Being able to coach the team, process things through, even deal with some of the moral distress that's going on. I think particularly when we have young patients who've been doing well and they're stricken with sudden illness and they're not going to make it, that can lead to a lot of team dynamics and moral distress and other issues. We actually have a moral distress component to ethics consultation, but even though it's not, I I don't know if it's official in palliative care in the same way. They spend a lot of time doing that. And there's a lot of ways that you can process and begin to deal with some of these issues. Well, we don't have time for case 3, which is fine. But I did want to pose this final question to people. The case actually set this up, but nonetheless, I think you can answer this question without knowing what the case is, and it's pretty obvious what the case was. Can discharge be considered safe if there's no VAD team to assume care? If this patient was actually leaving the hospital, wanted to go to a place where there was no VAD care available. Is that a safe discharge? We have to answer the second question. Oh, alrighty. Second question. What would you do in a situation in which the patient came from one place where there's a VAD team, came to us, wanted to go to another place with no VAD team? Would you keep the patient in the hospital and the patient was trying to leave? Would you discharge the patient to the street? Would you send the patient back to the new state where the patient wants to go, but there's no VAD team? Or would you pay for a plane ticket to go back to where the patient came from to the VAD team there? So what do we got, Don?
Okay, so for the first one, 83% said no, 8% said, 16% said maybe, and then 5% said yes. For the second one, 55% said pay for a plane ticket to state of origin, and the discharged patient to street is 22%. And then the keep patient in hospital with sitter and restraints, if necessary, is 22%.
All right, so there's a little bit more agreement on that, and I'm going to skip ahead to make, in the interest of time, just to make some important points about this. How many know that we have a discharge consult service that meets every week? One person in the audience. It's a good thing I didn't skip this. This is important. Denise, any comments about the discharge consult service?
So this is a multidisciplinary team with members of administration and everybody else that you need at that table, as well as people for the attending and other consulting teams. And this is the team you need to call when you're in this situation. They will help to figure out even when patients have diminished capacity, there are limits to the number of things we can do to keep them here. And because of that, so there are ethical issues there are legal issues, there are a bunch of different issues. And then of course we want to keep them as safe as possible. And so that is where you want to go immediately. Every week they meet. You can call Nancy Chamberlain or Ms. Cook or email them and say, I need my patient to be reviewed, and they will help you figure out what to do.
And I think that's particularly important, as you may be aware, this idea of discharge against medical advice. We're sort of not doing that anymore. Preferred is this PDD, or patient-directed discharge, and words matter. And so, it turns out there's a very common misconception that if you discharge a patient AMA, that the insurance company is not going to pay for that. That really is not true in most circumstances. So we don't need to worry about that whole thing. It's really about what's safe for the patient. If people are interested in this, we actually wrote a paper on this about some difficult situations that we've had recently. I'm happy to provide that for you. But the bottom line is difficult discharge consult service. Utilize them. In this particular case, patient went back to original state to the VAD team that was there and died 3 months later. So here's just our summary in our last few minutes. And then if we have any extra time, and I know we'll be around afterwards, use that withholding and withdrawal policy. You just cannot go wrong with that. We all want to acknowledge that D&A in cardiology can be very complicated. Denise did a great job of describing what assent is and how it's different than consent, informed consent. Use that too. And if you're contemplating unilateral withdrawal of anything, ethics, palliative care, and particularly the medical director's office needs to be involved as per the policy. There's complexities of hope and goals of care. I think everybody knows this. The nature of the resuscitative devices that we're using are different, as are their meaning to the patient. I love the point that Karen made about that. That's absolutely crucial. And we've elucidated that in some work. Please use the difficult discharge, I shouldn't say difficult, the discharge consult service. And again, the new terminology, patient direct discharge, or PDD. I'm going to leave you with the last quote that hopefully will encapsulate at least why I love doing ethics consultation. I don't know if Denise would agree with this, but from Dickens, a wonderful fact to reflect upon, that every human creature is constituted to be that profound secret and mystery to every other. And it is our job to be the detectives, to step into that secret and that mystery and walk alongside our patients and help them in their sometimes hour of direst need. So thank you very much for your attention. Other comments or questions? Denise, why don't you come up here, field the questions? I'll run around with the mics.
Thanks. It was lovely, as always. There was an article that was passed around to some of us on the ACHD team a couple of days ago from the New Yorker. And one of the things that stood it's essentially putting the pitch for how bad CPR actually can be, and the rib breaking and the moral distress and blah, all the things. But one of the things it raised was the idea of, instead of using DNR, using a phrase, allow natural death. And I wondered what your thoughts were about, back to the idea of language matters. Granting that natural with, you know, a morphine drip and Versed is not,
Right.
debate that, but whether or not you think that that phrase has any real merit to be used as far as a way of communicating more clearly with families what we're actually trying to do.
I do think it can be quite helpful, but I also do think we want to be reflective about it. And in some states and in some places, they use that terminology more than we do. But I do think you make a good point about how much terminology, or how much intervention we've already done, where natural can start to be weird. And I don't know if you want to say, if you would know better than me.
No, that's a really good point. And we don't want that to confuse patients either. They're like, wait a minute, morphine drip, that's not natural. So I think we have to be careful in that, but sometimes that really, I think it really resonates with people. Allowing is basically the conceptual model underneath that. I also want to call out Jillian in particular. Jillian sent me that same article. It's called The Hidden Dangers of CPR, or Hidden Harms of CPR, from the New Yorker. And it is very well written. It's about the COVID times and comes from a particular patient perspective, and the way that this palliative care physician was actually able to navigate that and use language that really helped elucidate what was going on. And so I do highly recommend it. I'm happy to send that to anyone who's interested in that. And Jillian sent that before this, and it really helped me in preparing for this. I want to thank her very much for that.
What do you think the role is in the consent process before we start a major intervention, before as a bridge to an end? I really like the comment about ECMO as a means to reach a goal, and if we can't reach that goal, then we need to revisit this. But at the same time, whenever we're consenting somebody, it's always when they're in dire need of an intervention and we're trying to save their life. And so we really only want to provide hope at that point. How do you navigate that?
So we, a few years ago, I wrote an article called The Bundling of Informed Consent and Advanced Directives, or something like that. And it argued for this idea, it's hard to do it in the emergent situation, but of exploring advanced directives and doing little goals of care and advanced care planning when you're doing the informed consent for something, and expanding this beyond the idea of, all right, here's the bleeding and the infection risk and whatever. And let's like, why are we doing this? And what are the longer term problems that we're going to run into, like can't get off of ECMO and things like that, and actually having that upfront discussion. I think it's a very complicated thing, but I think we should be doing more of that. And we actually separate into intermediate and long-term risks, some of which are, you know, you're stuck in a situation, can't get out of the ICU. So absolutely, I think that's a fabulous point. I don't know what Jim Fausto would say about that too, if he's still on.
And I see that we're a little bit past time. Jim, do you have something you want to say real quick?
I'll pass, actually. It's probably not quick, and it's more of a reflection, so I'll hand back.
Well, while you're on, I just want to say thank you very much for being with us. Your participation was a huge help. And I want to say I know we're past time, so I want to say thank you to everybody for being here and for participating. Take care.